Welcome everyone to today's webinar. I am Jessica Kim Cohen with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled "Enter a question for staff" and clicking send. We are looking forward to hearing your questions. In about a week following the webinar, we will be sending all registrants a copy of the presentation to the email you used to register. Please be patient as the post-webinar presentation of materials can take some time. I will now begin today's program by introducing our speaker. Dr. Ken Foden graduated from Michigan State University College of Osteopathic Medicine in 2005. He completed his residency at Ingham Regional Medical Center in Lansing, Michigan in 2010. Dr. Foden entered into private practice and has been at Munson Healthcare in Cadillac, Michigan since then. Munson is a small community hospital serving a rural population of 80,000 patients. Dr. Foden's practice is mixed surgical and endoscopic as a community general surgeon. His objective as a surgeon is to provide cost-effective and cutting-edge procedures in the community to attract and keep patients local so they can trust and enjoy the personalized care they can have in a community setting. At this time, I am pleased to turn the floor over to Dr. Foden to begin today's presentation.
Well, hello everyone. I want to thank Jessica for the introduction and want to go ahead and get started through with the PowerPoint. So today we're going to be talking about something that is kind of a hot button topic right now in minimally invasive surgery. A lot of hospitals and institutions feeling the pressure of dealing with the question of whether or not they should be embracing the robot. And this is kind of just a look at what our hospital did when we struggled with that question. As a quick disclaimer, this is basically just for general knowledge and just trying to keep everybody abreast of what we've done in our small town and kind of the decisions we've made and what led us to the decisions that we made. We're going to talk a little bit today kind of about the background, how we got to this discussion, what the state of surgery is today, and then trying to find that the sweet spot where all parties involved are having the best benefit. Going to talk about the two technologies that I've used together to answer the robotics question for our institution, which are Olympus 3D, and then a newer technology also that's called FlexDecks. We're going to look a little bit at some cost comparison versus robot and traditional laparoscopy. So I am an employed physician by Munson Healthcare Cadillac. As we discussed before, this is a rural hospital that is located in northern Michigan. Kind of everybody from Michigan refers to the hand, so I live right near the ring finger, right on the ring, basically. And I'm a consultant for Olympus and a shareholder with FlexDecks. Our hospital is a small community hospital in the truest sense of the word. We have 47 inpatient beds, and our OR consists of 4 operating rooms that is split between 27 different surgeons and a number of different specialties, including general surgery, orthopedics, urology, gynecology, ear, nose, and throat. I would say probably about a year and a half to 2 years ago, our hospital administration approached us in the conversation of how do we recruit more providers to the area and how do we retain the providers that we have. They were entertaining the idea of picking up a robotics system. And for just transparency, when we talk about robotics, we're talking about basically when we look at all of the robotic systems that are available in the US, there is one. So we would be looking at the need or the benefit of adding the robotic vendor here and whether that would bolster our community and in terms of the cases that we could provide and if we could retain patients and be able to provide them better care close to home so they don't have to travel to remote, or sorry, not to remote places, but to tertiary care centers. We have two large tertiary care centers. One is about 47 miles north of us, and another is about 95 miles south of us. So we went through a process where we had a consulting firm. This was an independent consulting firm that would analyze your hospital and the demographics of your hospital and come down with a recommendation whether or not they felt that robotics would benefit you. Again, keeping in mind there is one robotic vendor that's currently available. And these are the basic points that came through in terms of the key points that they wanted to drive home and how they could make a small hospital benefit by adding robotics. And so they would provide guidance to us on how to create a robotic facility, how to keep people trained and get people up to speed or get them to the point where they could become facile or dexterous on the robot and be able to make it efficient. They would go through with the operating surgeons and the technicians in the surgery suite to limit the amount of instruments per case because each instrument has an associated cost. So they would help to tweak the number of instruments that you're using to help drive the cost down. They would help you to, they would help us, to have best-in-class turnover, which would include setup times and be able to ensure that there's appropriate flow through and use of the OR time. They would aim to get our facility to be a top 10% in terms of cut to close times. And they would demonstrate that robotic cases could have shorter length of stays when compared to open. They also wanted to help us limit our adverse effects or our adverse events such as readmissions or surgical site infections. And then they found that they recommended that if we were able to do all of these things, people would seek us out for our technology, which would bring a better payer mix, and therefore patients, if there was out-migration, we could stem the out-migration and potentially recruit more patients to come to our facility. As you look at this series of recommendations, the 7 points I have listed here, these are really pretty much what any surgical quality improvement program tries to do. Limit the amount of instruments you use, whether it's an open case, whether it's a laparoscopic case or a minimally invasive case or a robotics case. Obviously, any surgeon who has been involved in the OR and any administrator who's ever had a conversation with a surgeon has had the conversation about how to get better turnovers. And turnovers get better and they get worse. It all depends on how closely we're watching them. In terms of getting a facility to become the top 10% in terms of efficiency, that just has to do with how competent the surgeon is, whether it's minimally invasive, whether it's open. And then obviously they did look at the shorter length of stays, which I'll actually address later on with a recent study that came out from Dr. Lowenfels through Medscape. And then, of course, limiting adverse events. These are all things that are not robot specific. And when we saw that, we said, well, that there's no special sauce there. So we decided to try and look at different things. When we look at this, the impetus of our care is to try and provide the best quality with the highest service at the lowest cost, and that is how you get the value. So this is kind of the modus operandi that we're looking at when we want to talk about trying to find that sweet spot. Certainly, if you can maximize quality, maximize service, and minimize costs, it's going to have the best-in-class value. So as we look at this, hospitals, surgeons, we're not the only ones who find the cost of care important. This is a little graphic that we've gotten from the advisory board. And for those of us who are surgeons, this is actually a little bit disappointing because you can see that when it comes down to making the decision in terms of where you have your surgery done, only 4.9% of the decision is based on the quality of the surgeon. I can tell you that hurts my feelings a little bit. I would hope that people would be pursuing us because of the quality that I can offer them. But you can't argue with the facts, I guess. But what you see here is 53.2% of the deciding factor is the cost of surgery. Well, in today's day and age where everybody has insurance, or at least we're to believe that everybody has insurance, why is the cost of surgery so critical? Well, I look at my pay stub every 2 weeks, and I see what the cost of my healthcare coverage is, and I also have been in conversations with my insurance company and have found out that over the last 9 years, we have had significant increases in out-of-pocket expenses and co-pays. So the cost of the surgery does get transferred through to the patient. There's also the factor of travel time to a hospital. So, of course, there is an advantage to having good care locally. That obviously only weighs in as a total of 20% because people will go to a bigger institution and spend more time traveling if that is necessary. For the primary care physicians who may be watching, unfortunately, only about 10% of your recommendation only weighs in about 10% in their decision. And then, of course, hospital affiliation and then the location of the follow-up visit. So this is to drive home the point that cost is important. And I think that as time progresses, we're going to continue to see cost will continue to be a driving factor in healthcare, and not just nationally here in the U.S., but I think internationally. So where are we with surgery today? I have an inset here of kind of one of the old-fashioned operating theaters where surgery was, at that point, we would consider it maximally invasive. You'd have an ether concoction for your sedation, and the big question was, could we make it through the surgery? And here we are now where we're doing colon resections through incisions that are as big as a pen, and then sending patients home within 2 days or 1 day, depending on how their outcomes are going. So how did the pendulum swing from what I would consider maximally invasive surgery to where we are with minimally invasive surgery? And of course, the pendulum is not yet done swinging. We are going to continue to swing to become more and more advanced and more minimally invasive. What has really changed everything in surgery was in the late 80s when laparoscopy came to the forefront. That changed about a 100-year history of modern surgery in an overnight. And since then, surgical advances have exploded like the atom bomb, where we've had substantial innovations in surgery. We've had advancements since then in camera optics, cauterization, stapling, vessel sealing, and then the advent of the robotics devices that came to the market around 2000. However, in traditional straight stick laparoscopy, there has been limited advancements. Even today, the instruments that I use for a gallbladder routinely are the same that were developed in 89 and 90 when we first started doing laparoscopic surgery, because there isn't really been anything that has given us the great option for minimally invasive where we could have any good facile or tactile perception laparoscopically until recently. Many of the devices that have been out there, I would have to give you the analogy that they're much like using chopsticks. You can go in and you can go out, and if you rotate your wrist or move your fingers, you can get rotation on the end effector of your device. But never could you work like you're working with your fingertips, where you're able to move as though your wrist is moving inside of a patient. Fast forward to the advancement of robotic surgery, and robotic surgery was the first platform that offered us wristed instrumentation. So as we're looking and trying to find this sweet spot in surgery where we can give the best cost, have the best performance, have good control, and of course have optimal outcomes, we look, traditional laparoscopy has been there and has minimally changed other than optics and vessel sealers, but all the devices essentially work the same: open, close, rotate your arm, and you can get the mobility that you seek. These are low cost, there's low dexterity, they're less intuitive, and they have very well established outcomes. There has been reams and reams of papers that have been written about the advantages of laparoscopy, and it's an unarguable fact that the advent of laparoscopy has benefited patients. We look at the other end of the spectrum when you talk about minimally invasive, and we're looking in terms of the robotic platform. There is an extremely high cost to the tune of $1 million for a used device, up to $2 million for the newest devices. However, with that comes phenomenal dexterity. it is like working with your fingertips inside of a patient. It has intuitive control. There's haptic feedback that you can get into your fingertips while you're doing the surgery and while you're grasping instrumentation or tissue. There hasn't been very much data in this, or there hasn't been very much. There are certainly many publications, but in terms of comparison to minimally invasive surgery, in terms of looking at cost, in terms of looking at outcomes, certainly more articles are coming out, and every month new articles are coming out. I will cite one later that was just published in January of this year, but it's not to the point yet where you could say unequivocally this is the standard of care. So what we're doing now is we're going to basically try and find a high function, high value product. We've already gone over basically where we stand with traditional laparoscopy, with low function but high value. You can buy a laparoscopic instrument for anywhere from $200 to $700. That'll be straight stick. It'll go in and out. It'll rotate left and right if you rotate your wrist or your arm. And you can have vessel sealers, staplers, you can have clips, you can have ligators. They even have straight stick laparoscopic needle drivers, so you could put a curved needle inside of a patient and you would be able to sew. I can tell you not many surgeons today are doing that because it is very difficult to pick up. There is such a thing as a maverick course where you can become where you can train yourself or go through a series of different training protocols to get yourself so you can be facile with sewing laparoscopically. And then, of course, on the opposite end of the spectrum, we have the robot, or the Da Vinci robot from Intuitive Surgical. It's fairly expensive, 2.5 to 1 million to 2.5 million entry cost, and then there's the maintenance cost that will run you anywhere around $150,000 a month. Of course, that's prorated, $150,000 a year, and that'll be prorated over the course of over the year, so you're paying it as a monthly fee. And this will, of course, need to be addressed somehow in terms of how this cost gets distributed across, because there is no increased reimbursement by any CMS, Blue Cross, Aetna for using the robotic platform. There are codes for laparoscopic surgery, there are codes for open surgery. If you put the code in for a laparoscopic surgery, it will reimburse you for wherever you fall on this graphic here. Whatever instrumentation you use, the reimbursement will be the same. When we were looking for our hospital, what we needed to do, we wanted to be able to reach some of the dexterity and some of the ability that you have with Da Vinci, but we wanted to do it at a cost that was more in line with laparoscopy, and that's why we were able to entertain Olympus and looked at their new Endo Eye, which is a 3D camera system that actually can operate off of any of their other platforms. And they've already kind of made their mark in optics, and they do a phenomenal job with their colonoscopes, and there's interchangeability between their Endo Eye platform and their optic systems that they use for endoscopy. Being in a community setting, I do 40% of my surgery is endoscopy and 60% is surgery. So there's that familiarity with the device and the ability to be able to be versatile going between the two different devices. And then starting last year around January, a new product came to market, which is the FlexDecks needle driver. They currently only have one device available, and it is exactly what it says. It is a flexible, dexterous needle driver. When I was first looking at how we could answer the robotic question, I thought all we need to do is add the FlexDecks. We'll be able to do this because it has wristed capability. I can turn my needle driver to 90 degrees. I can rotate an infinity rotation, and I'll be just fine. So we added that, and in March, I did my first case with that. Well, my case lengths immediately went up to twice as long as they were, and I couldn't figure out what I was missing. As we continued to go along the learning curve with picking up that technology, we started entertaining the idea of adding in 3D, because as you look at what Intuitive offers when they have their wristed technology, it is always coupled with 3D. Certainly, if you wanted to, you could switch off to go to 2D, but what is a true finding is when you go into 2D, it is like walking around with a blindfold on one eye. You have no depth perception. You have no ability to see fine motion and fine movements. And so when we coupled FlexDecks with the Olympus Endo eye, I was able to decrease my surgical time significantly and get back down to almost where I was when I was doing things laparoscopic. And of course, I'd been doing all of my traditional laparoscopy in 2D because that is what we had available. And any surgeon who has been trained in 2D has done thousands of cases and could do them. When I first started doing it, I figured I only needed 3D for my advanced laparoscopy, but now I use it for every case because the clarity and the perception is that much better. So how does this what does that have to do with anything? It's basically where we're going here, or am I just going to blow my horn about the new technologies we're using? Community hospitals in the U.S. have been the huge target right now for robotics. They have pretty much full penetration at any tertiary care center. Any university setting, any tertiary care center will have, the question shouldn't be, do they have a robot? The question will be, how many robots do you have? And so with that market essentially being saturated, they've started coming after community hospitals. They approached our hospital around 2010 and said, would you like to buy a robot? We said, I don't think it's appropriate at this time for where our community stands, since there's 4 general surgeons. And we see that there could be a value for it, but at that point it wasn't really valuable for general surgery. They said, that's okay. We're bringing a robot down anyway. We're going to have a surgeon who works outside the community showcase it for everybody else so that patients who want to have the robotic surgeries can come to a different hospital. And that's kind of a marketing technique that we've seen used. I don't know if that's the way that they do it traditionally, but that's what we saw in our own community. So as we were approached and thinking about whether or not we needed to add a robot, our entire OR budget at our hospital is $32 million. That is all cost across all surgeons and all specialties. We have 27 surgeons that use our staff, that use our OR. 2 to 3 of us, 2 to 3 of the 27 would be interested in picking up robotic technology. I would be one of them, but I wouldn't use it for every case because I would use it on the technically challenging cases, the hernias, things that are very suture intensive or that would require a lot of sewing, because it doesn't necessarily need to be used in something that would be a straightforward case like a gallbladder, which is, of course, the gold standard type of a surgery. Anybody who does surgery today in general surgery can do a laparoscopic gallbladder. Not all general surgeons will be doing other advanced laparoscopies such as ventral hernias or paraesophageal hernias or inguinal hernias. A lot of those cases will still be done open or will be transferred out to a larger center where they can be done laparoscopic. So if you look at our budget being $32 million and you ask us to spend $1 to $2 million on it, that is anywhere from 1/32 to 1/16 of our entire budget for 2 surgeons to use. I can tell you I would be very unpopular the next time we had a Department of Surgery meeting if I had asked the hospital to spend that much of our budget on one device. So why did we look at FlexDecks? When we looked at FlexDecks, we basically found that with the costs we were paying for different things such as tackers, endo stitches, and endo stitch reloads for the foregut surgery and for the inguinal hernia surgeries that I do, FlexDecks would be essentially cost neutral. But it would give me the tactile ability and the ability to kind of emulate what is being done on the Da Vinci platforms. So we added FlexDecks, and then I just added an Ethibond suture, which is going to run around $3 or $4. I added vicryl sutures in order to fix my meshes in, which would run around the same $3 to $4. And then we used the newer symmetric or quill, which is a knotless suture that we can put in. Of course, that's a little more expensive, probably in the $18 to $20 per suture, but nowhere near the $500 or the $600 cost that you'd be spending on a tacker, which would be limited numbers that you could use, and I could sew all day long with as many sutures as I want to. This allowed me to have better fixation, and I could now accomplish larger inguinal hernias and get better peritoneal closure. I don't know how many surgeons are online, but we've probably all had the experience where you get in there laparoscopically and you say, wow, this is a bigger hernia than I thought it would be. I'm not sure if I can get the mesh to fit and stay in the right position, or if I'm just going to make a very expensive hernia sac the next time this patient coughs and the entire mesh migrates down into the scrotum. I had that frustration before, and you can't put tacks down in the groin and I'm just going to use the groin as an example. There are very big vessels. The blood supply to the leg is within about 3/4 of an inch of where your major dissection happens, and you can't just willy-nilly go put metal tacks or even dissolvable tacks down near the femoral artery or the femoral vein. You can, but you would have a very long visit and a very short conversation with your community vascular surgeon. And then peritoneal closure, as we strip down the lining of the abdomen to put in a non-coated mesh, which is a cheaper mesh and a better mesh to use in the groin, you always run the risk of having exposed mesh. Anybody who stays up late at night sees the commercials where now lawyers are trying to come after us for using meshes. And if you have a mesh that is not supposed to be exposed to the bowel, but does get exposed to the bowel, it can lead to further complications. With the FlexDecks, I could sew everything. I can drive a needle directly through the periosteum and sew my mesh right in there with 100% confidence that it will never move. In terms of docking time, the docking time for docking the Da Vinci system, which would be after you've gotten the patient to sleep, you'll make an incision, you'll get the air inside the abdomen so you can do your work. Now you have to bring the robot in, hook it in, and when it's hooked in, the bed can no longer move. It has to stay in a stable position, and you put the multiple arms in through your operating port sites. And the docking time could run anywhere 10 to 15 to 20 minutes. Certainly, the leaner an institution is and the more they do robotic cases, I have no doubt that they can get their docking times down. My total length to dock, you see my instrument there on my wrist over on the side picture. That took me about 47 seconds to put on. There's a Velcro strap that I put around my wrist, and then I click directly into that arm, and we're done. That quick. We already talked a little bit about why I decided to add the Olympus Endo eye, and it really had to do with the fact that I couldn't see. So I have 5 kids. Last spring, I had my kids wash the window of my truck. Looked great. I gave them each $5. Well, I didn't give them each $5 for that. That'd be way too much to pay for them to wash it. But it looked great. And then the next morning, as I drove down my driveway and the sun was coming up, I saw streaks and I saw grease and I saw everything. I think what they had done is they had taken the polish and rubbed that across the windshield because it was terrible. So I had to roll my window down, stick my head out in order to drive to work. This is what it's like when you operate with the current optics that we had. Our optics was old. We had a lens that was about 18 inches away from the actual operating field, so the camera head was back. We're constantly having to dial in and adjust. And the clearest picture you could get is the picture you could get if you took Vaseline and wrapped it over your eye. So we started looking at what we could do different. This is where Olympus Endo eye came in. If you look at the Endo eye, you can see that the camera port and the light cord comes across the back. We have that graphic over on the side. If you go back, I'm just going to do this right here. This thing that is on my right hand has a very high profile. It will come into contact with the camera unless I move my ports significantly, which I've had to adjust my cases a little bit. But if you were to put your traditional laparoscopy, will have its light cord coming in at a 90-degree angle to that, and you will be constantly fighting with it and having very poor dexterity. This is something that has been established in laparoscopy for a long time. You always have to worry about your instruments fighting with each other. We call it sword fighting in the OR. So we added the FlexDecks 3D, and I had done, or the Olympus 3D with the FlexDecks. I had done my first 25 cases from about March 1st until May 25th. I had completed 25 cases, and my operating times were up twice. Hospital doesn't like it when your operating time doubles because that means you get less cases done, and we already talked about you can only bill X amount for any case no matter how long it takes you. So of course the sweet spot is do more cases in a shorter period of time. Everybody's happy. So we added 3D, and as soon as we pushed the button and went to 3D, it changed everything. My cases immediately went back down to within 10 minutes of what my previous case length was. Since then, I think I've done another 100 in 3D, and I've gotten to the point where I don't even use it just when I'm doing FlexDecks cases where it's very suture intensive. I use it on every opportunity that I have. The basic take-home point here, what we had been missing is what Da Vinci does offer. 3D optics, wristed technology. If you're going to use an articulating device that requires 3D manipulation, you need to be able to see in 3D. So we've been able to find that between Olympus and FlexDecks, we've gotten an economic benefit. We have direct procedural costs that are affected. There's also the amortization capital of equipment costs. Of course, there's an additional cost to adding 3D. Every OR currently, I would imagine, has some sort of optics system in there. You already have optics sitting in your OR. It would have cost you somewhere around $100,000 to $150,000. There will be an increased cost today by adding 3D, but I do believe that within 5 years, every OR is going to have 3D, because as surgeons start to adopt it, it's a very simple thing. If you have somebody who can't change and says, I have to do it all in 2D, that's easy. Push the button, you can go back to 2D. But with the chip and tip technology that Olympus has, you have phenomenal clarity. And I can tell you, I haven't operated with Vaseline in my eyes in over a year. OR time is also a direct benefit. Okay, there's no docking time. So why does that matter? Well, it's because it's efficient. We talked about it's a minute to dock. If I need to move the patient, I ask anesthesia to move the patient. I don't have to undock, have them put the patient into a different position so they're banked to the right or banked to the left or tilted this way or tilted that way. None of that has to happen. I do it just like I would do any other laparoscopic case. Adding these two, there is no monthly fee. There is no updates when the new technology comes out. There's also not the risk of them saying, your model is 3 years old, we no longer service that. I do all my own accounting on QuickBook, and I tell you what, that was the best thing they ever did, because every 2 years they tell you, we won't service your model, you need to buy our new one. And that happens across all specialties when you start getting into something that's 100% computerized. The beauty of the FlexDecks is you are the computer. There are no special staffing requirements when you add these two technologies. We did not have to send anyone out to go do any training. We did not have to spend, and there's a huge capital cost with that. If you're going to take 3 scrub techs and 2 RNs and send them out of the city or out of the state for 2 weeks of training, and then have your surgeon stop operating so that they can work on a console to do 10 hours or 20 hours in order to become facile with it, those are human resources costs, and there is nothing according to that. If you have a surgeon who wants to adopt this, the FlexDecks company can get them set up with training at their convenience, either have them come to a site or can go to the surgeon themselves and go through some training. Of course, there is some labor-intensive value to it, but anything that has real value will have some cost to it. And here's a real advantage. If I was on call, which nobody loves call, but if I was on call and I needed to use one of these in the middle of the night, I don't have to call in the robotics team. I don't have to open the robotics room. I don't have to do anything different. All I have to do is say, let's hit the button and go to 3D, and I'll slap it on my wrist and we'll be moving on in the next 47 seconds. When we look at the cost comparison of Olympus 3D and FlexDecks, this right here is a graphic that was published by General Surgery News in January of 2017. Off to the right is my inset that shows my actual all-in cost. I want to highlight up here that they're saying that all mesh is assumed equal. I will tell you my mesh cost me $89. It is a non-coated mesh that goes above the peritoneum, and then I close the peritoneum over the top of it. I'm on a number of different social media websites where surgeons post what they do, and I can tell you that a number of robotic surgeons who use the robot because it allows you to sew, that is the real advance that it gives you, will go in and will put in a $1,300 mesh that has, it's like a Velcro piece because it'll hold onto the tissue, and they don't sew it in at all. They lay it in, and of course they would say that it's not necessary to sew it in because 1, it holds itself in place, and 2, if you're going to sew something, you could hurt the tissue. But that never stopped anybody when they use tackers, because though the tissue can be sensitive, if you don't necrose the tissue or tie it down tight when you tie, you're just using it to hold the mesh in position so it doesn't move, then you could be just fine. But as you look at these costs, you're like, well, gosh, that's not convincing. Well, we're essentially cost neutral as you look across the Da Vinci 8mm, the Da Vinci 5mm, which has 20 uses that they can use for their instruments. And then laparoscopy, their point when they published this graphic was that they can come in cheaper than traditional laparoscopy, which they're demonstrating right here. The fixation that is used in traditional laparoscopy is a tacker, whether it's a permanent tacker or an absorbable tacker. Depending on the size of the hernia, you may need 1 or you may need 2. With what I've been able to accomplish, I use the needle driver. I hit the button and I go into 3D, and I'm able to do the whole thing at an all-in cost of about $1140, which is pretty much across the table identical to what you can do with the robotics cases. The other thing that they're not including in here is your amortization schedule for your robot. Let's just anticipate you have about a 5-year amortization schedule. As you look at that, if you're in a large institution where the robot is being used for 7 to 8 cases, 5 days a week, of course your amortization will be low, maybe $160 a case just to turn it on, maybe $200 a case. You'll have to look at your own system to figure out what that value will be. I can tell you, at a small hospital, if you're going to amortize a $2 million cost across 5 years, which is an appropriate amortization schedule, you may approach as much as $2,500 or $2,000 just to turn it on. And you may find that your surgeons are starting to use it for cases that don't necessarily need to be using it on, and it ends up going from being a benefit to being a millstone around your neck. This is potentially pie in the sky conjecturing here, but you have to address all costs and you have to look at all things. That's part of the bonus, or that's part of the onus that lies on us as healthcare professionals. Here we're looking at inguinal hernias on that same type of a graphic. You can see here again, I apparently come in, as you would look at this graphic, as a more expensive alternative than the Da Vinci robot. This is also, I'm better than the traditional laparoscopic tap, and I'm more expensive than the laparoscopic tap. But again, as you're looking at here, I want to point out one more time, mesh is not included. The mesh that I use, unless you use mosquito netting, I don't think you can go more cost effective than that. So the question is, am I cutting corners by using cheaper mesh? No. I use a lightweight macroporous polypropylene mesh. It has good expansive strength, it has good high tensile strength, and it can lay in there, and it has very little pain for the patients afterwards. It doesn't irritate the nerves, and it's easy to work with laparoscopically, and I'm able to sew it in directly to the bone so that it doesn't move, which is the same thing I would do open. And that's a big point I want to hit. The gold standard for surgery is open surgery. That's what everything has to be compared to. You have to be better than open surgery. And if I can replicate what I do open, minimally invasive, that's where we want to be. Traditionally, what we've said is we've kind of turned a blind eye and said, well, we can't do it exactly the way we do it open. You know, like for instance, ventral hernias. When we started doing ventral hernias laparoscopically, nobody closed the defect. So you would reduce a hernia, you'd put a piece of mesh across there, you'd wake the patient up and you'd say your hernia is fixed. Well, all you've ever done is you've just bridged across the tissue. If you were to do it open, you would close the defect, you would get tissue approximation, and you would leave a mesh in to reinforce it. And I can tell you that in laparoscopy and in advanced minimally invasive surgery, that pendulum is swinging, and most surgeons these days are closing the defect. Well, why did we not close the defect before? We didn't close the defect because we didn't have anything that could do it. That is one thing that Da Vinci's robotic platform has really allowed people to do. That's also something that I've been able to do with the FlexDecks. The thing that we were able to find is that comparatively, I've been able to get about an 18% time savings in the operating room by combining the wristed technology and the 3D technology. Certainly my first 25 cases I'm working on analyzing that data to write a paper to show where I was on my learning curve with the first 25 in 2D and where I am now with my last 75 in 3D. And I'll be working on trying to get that around to publish that at some point. But as I look at the raw data, it looks like it's around about an 18% time savings. After I added the 3D FlexDecks on 5/24 last year, again, my case time was cut in total by about 9%, and my cut to close time was decreased by 18%. Of course, there's a lot of different variables that go into all of that. But we at our hospital charge around about $5,000 an hour for our OR. Why is this important? If a case goes over an hour, you get into your second hour and you start looking at, you're still not going to get paid anymore, or the hospital, no increased collections can happen. It's a set rate. So the sweet spot is to get your surgeries done in less than an hour, because if you were to budget it out, it's $289 a minute. And that is why turnover times are the things that surgeons will constantly go to administration to talk to them about, because that is the cost. So if you send staffing home to cut $12 an hour in pay and you increase your turnover time by 20 minutes, Well, that's what brings surgeons into administration. So utilizing the OR when it's open and when it's staffed is the sweet spot, and I think that Olympus 3D and FlexDecks allowed me to do that. So personally, I've done 120 cases. I think I'm actually up to 125 since March 1st of 2017. I've been able to use a lot of different types of cases. I use it on my groin hernias. I use it on ventral hernias, and I'm doing a variety of different types of ventral hernias. Some of them, the mesh is inside the abdomen. Some of them, it's outside the abdomen, but above the smooth lining of the abdomen, and others, it's just directly behind the muscle. I also use it extensively on my paraesophageal hernias. Again, we've talked about the first 25. The learning curve with 3D, incredibly short. The learning curve with the FlexDecks was probably anywhere between 5 and 10 cases, depending on how quickly you do them and how committed you are to them. But it's a quick technology to pick up. We're getting close to the end here, but I did want to address just a couple of things. We had talked about that I've gotten over 100 cases here. I'm pulling data right now from our hospital. It's very raw data and hasn't been fully analyzed yet. But because you've seen the graphics, if I compare to what is published out there for some of these robotics cases, it's not really overwhelming. It doesn't have that wow factor. Inside of our hospital system, I've looked at the cost and I looked at the time, and I've compared directly to, in our hospital system, we have 2 robot platforms. So I've looked at basically 20 of my inguinal hernias compared to 49 inguinal hernias from robotic people who have been doing robotics for a long time. And I've found that basically I'm within a minute of their times when it comes to cut to close time and total length of time in the OR. But this is, mind you, including my first 25 cases where my case times doubled. So part of what I'm working on for my publication will be is where was I before, where am I now? Because I think that the data will show that I come in at a shorter time. And of course, it's not about the time necessarily. You need to do the safest surgery possible, but if you can do the safest surgery possible in 35 minutes as opposed to 45 minutes, you should do it in 35 minutes. The collection data or the cost data is the part that for me is going to be the most interesting. Looking at it again with raw data, we're looking at a difference in collections somewhere between $1,600 for a laparoscopic case and $160 for a robotic case, which is a 10x factor in terms of potential difference in cost of the case. We'll just phrase it that way. So I will be working on a paper that shows that, and that's in ventral hernias. In inguinal hernias, it's not near as compelling. Instead of being a 10x difference, it ranges between a 3x and a 6x difference. So stay tuned. We should be coming together with some of that data here a little bit later, but that's from looking at a retrospective. We're going to do a retrospective study that goes from 3/1/17 to 3/1/18, comparing directly my FlexDecks cases to robotic cases at our institution so that there isn't any bias necessarily. The article that I alluded to, because you're going to say, again, looking at my graphics that I have right here, it looks pretty cost neutral. There is a recent article that was put into Medscape by Dr. Lowenfels on 1/5/2018. This is published in the Journal of American College of Surgeons if you want to look at it. It is a review of 92,835 cases. To me, that has a lot of power. It looked at, admittedly, 4% of the cases were conducted robotic and 96% were laparoscopic, but they looked at costs. And they said with a p-value of 0.001, that's for statistical significance, robotic cases were higher in all cases, ranging from 6.4% on a hysterectomy, so that was the closest you could get. Robotics would be 6.4% higher than a laparoscopic hysterectomy. To the other end of the spectrum would be 28% on a left hemicolectomy, and they were looking at inguinal hernias, paraesophageal hernias, ventral hernias, So there's articles that are out there that are confirming, and I think they're pretty strong data that's confirming that robotics does have an added cost when compared to laparoscopy. They did, however, and this was one of the things that the consulting firm told us to look at, robotics does cut the length of stay. They cut the length of stay by about 1.8 days after surgery. But associated with that, they also had a higher overall cost, which means that the hospital's overall cost, we tend to think that our hospital's cost is closely tied to the length of stay. If you add a robot in, your length of stay is shorter, but your overall cost is up. Now, that doesn't necessarily mean it's a disadvantage, because when that patient leaves that bed, you can bring another one in. So you have to take that into consideration. And this is based on a 2017 10-year review article that was presented at the ACS recently. So we're going to pretty much get down to the brass tacks here and wrap it up. I'll blitz through this very quickly. Here we're going to compare a traditional laparoscopic surgery without FlexDecks to one using FlexDecks. The cost of the mesh is the main difference. So if you're an administrator, you should take a look at what the costs of your meshes are that you're using. The mesh I use, again, runs $89, and so I can do it all-in cost of $11.84. This is whether I'm doing a ventral or an inguinal hernia. And then this is basically just summing up the data from the other slides if you were to add together all those other cases. Unfortunately, it says Ultra Pro Advanced Mesh. This is using a Proceed mesh, which is the one that, as I review many robotic cases online, whether it be YouTube or Facebook, the majority of them, or many of them, are using some sort of a 3D Max type of a mesh or a Pro Grip mesh, which has significantly higher costs. In terms of looking at this here, we're talking about universal technology. The Olympus 3D can be used in anything you use laparoscopic. Your gynecologist can use it on one case, a thoracic surgeon can use it the next case, a general surgeon can use it the next case, a urologist can use it the next case. You don't have to have specific training. If you want to use 3D, put on the glasses and push the button. I mean, it's universal. Okay, it offers better optics than what we had currently available. Certainly there are other, we have to give a nod, there are other providers that are out there, but this has chip-in-tip technology that has the ability to adjust itself, so you don't have to rely on somebody to adjust down your image in order to get better focal depth and everything like that. This is durable, okay? You can put it through the autoclave dozens, hundreds of times. You can get it clean, use it. I don't want to say you can drop it. There may or may not have been one dropped at our institution, and we get them working, okay? It's flexible. When you use the Endo eye, they've basically taken their endoscopic technology and they've been able to adopt it across laparoscopy, so you can look around corners and you can turn it on 3D and look around corners. I use it a lot in the groin and in the paraesophageal area because these are the most straightforward areas where you need the most depth perception. I've started doing many paraesophageals where I have to dissect well up into the chest and get below the heart, almost up to the carina, which is way up inside the chest. And I have to be able to see where the vessels are because the aorta lives in this area, the inferior vena cava lives in this area, the pleura to the lungs live in this area. And that added depth perception and the clarity to see which tissue I'm grabbing, it was not possible before. Anytime I'm sewing, with doing it either in the groin or in the foregut, I'm sewing directly in front of myself, and it allows me to turn the needle at a 90 degree and sew directly towards myself so I can see. You don't have that with any of the traditional needle drivers. So, I am long-winded, I apologize. Cost of care is important to both the hospitals and the patients, and this is a major deciding factor as we address issues. And so if a surgeon is going to be turn a blind eye to the cost, they may have to consider moving to a different institution at some point in the future. I don't know when that will happen, but if you go to any talk statewide or nationwide, cost of care and cost containment is one of the main conversations that has to happen. Time savings, we talked a little bit about my time savings. It looks like I'm over 18% with adding Olympus 3D and FlexDecks, and that would be FlexDecks itself increased my time. With the addition of Olympus 3D, when I get out my paper, I'm going to show that it's going to be a significant time savings. At this point, I'm just going to say in general, it looks like it's about 18%. we've experienced a decrease in our direct procedural costs, especially when you compare robotics to traditional laparoscopy. The tables that we've included here may not show that, but I'm just having to quote what somebody else has published. However, I would turn you again to Dr. Lowenfeld's article where he references a comprehensive review of 92,000 cases. I think that should be pretty powerful when it says that procedural costs are higher robotic, and you could just again say it ranges from 6.4 to 28% per case. When you have the tactile feel that you can get with a wristed laparoscopic instrument such as FlexDecks, and you combine that with the depth perception of Olympus 3D, that right there is the special sauce that you need so you can have a low-cost, full-function robotic technology in your cases. Now I'm going to open it up for questions.
Thank you, Dr. Bowden, for that fantastic presentation. We will now begin today's question and answer session. Please submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We will try to get through as many questions as we have time for. Dr. Bowden, our first question is about the consulting firm that you mentioned at the top of the presentation. Can you disclose the consulting firm that you use, and what was the timeline for the consulting firm's analysis?
We were working with a group that was called CAVA. I don't remember exactly what their initials stand for, but it was CAVA. It's a conglomeration of a couple of different surgeons who are robotic surgeons, and they are an independent consulting firm. I want to say it was probably around a 3 to 4 month analysis that they did.
Great, thank you so much for going over that. Our next question is, do you have a value analysis committee to decide new products for the OR? If so, how were you involved in that process?
We do have a value analysis. What it comes down to is I present basically what I think it can compare to, and then they would approve it on a limited basis. I need to demonstrate what I'm going to replace so that they can associate the cost of what I'm replacing. So for instance, when it came to adding FlexDecks, because that is a disposable device currently, and it is a recurring cost in terms of that. When I looked to add FlexDecks, I told them that I would stop using my endo stitch, which I think runs around $180 for an endo stitch, and then $60 a cartridge for your sutures. So if you're going to do a large paraesophageal hernia where you're using that device with 8 sutures, you're going to come close to $700. I would also be able to replace the the tacking devices that I was using, which run a range of the $500 to $600 range, depending where you are on contract. So when we were able to demonstrate that I could do this, I was able to get it through our value committee. In terms of 3D, there was very little work that needed to be done with that. When you're looking to upgrade your optics, it's basically what type of optics do you want and why do you think there would be a benefit to this versus another. We did a trial with 3D, and when they saw that I could cut my time down in half, it was basically dumb money.
Great. And this next audience member asks, what are the surgeon social media sites that were mentioned? Sure.
So there are a number of closed groups that surgeons get on, which you have to be vetted to get into, where we talk about and present different things that we're doing. International Hernia Consortium, different ones through SAGES. SAGES has a robotics platform. These are available on Facebook. I think that there are also some other independent standing ones that are available. But I'm a member of a number of those different collaborations, which really, it allows for a lot of peer-to-peer review, and actually a lot of really phenomenal stuff is coming out of these. And I want to take my hat off to the people who organize the International Hernia Consortium. I'm connected with surgeons in Turkey, in Japan, in Colombia, Mexico, and we're able to share interesting cases we've had and learn from each other. And honestly, a lot of learning that is going to happen in the future between surgeons is going to happen on video and social media platforms, and that's something that's been really great for us to be able to do. I've even started my own YouTube channel to try and educate my patients on the things that I do, and be able to kind of be in contact with industry and kind of show different things that I've accomplished, and it's a great forum for that.
That's a great point. Thanks so much. This next audience member asks, is this technology applicable to other specialties?
Oh, yes, definitely. I think we talked a little bit about that in terms of the optics for 3D. As we talked about, every surgical suite has some sort of an optics system. We have a tower currently that can be used by anyone who wants to place a scope inside of a person. We're talking, again, for instance, urology, gynecology, thoracic surgery, general surgery. Basically, if you can put a scope in somebody, you could use this. In terms of the flexible needle driver, there are robotic trained and robot utilizing urologists who are now starting to use the FlexDecks for prostatectomies, which will be a huge thing as that starts to get adopted and people start getting trained in residency. Because what has been happening, there's been basically an essential 100% I don't want to say 100%. There's been a high conversion rate between urologists and gynecologists to the robotic platform. And as small institutions such as ourselves try to recruit, that ends up being one of the main questions. Well, why would I go there if you don't have a robot? How can I do a prostatectomy or a nephrectomy? I have to have a robot. I think that this device is going to even the playing field as it has for us, because I'm able to do robotic cases with robotic outcomes at laparoscopic costs.
Great. Our next question focuses on patient education. The question asks, does your hospital do any patient education on procedure costs?
We don't, actually, and that's a great question that you brought up. We don't do education on procedure cost. We do a lot of education. The hot button recently in surgery has been enhanced recovery after surgery. So we do a lot more patient education than we used to, and we point out why we are doing that, because it decreases risk of infection, it decreases risk of any complications, shortens length of stay. And so we have indirect conversations about cost, but we do not directly discuss cost yet, to my knowledge, with our patients. I do not.
Thanks so much for clarifying that. And it looks like this will be our last question that we have time for today. But this audience member asks, you focused mostly on cost. Can you share how your outcomes have fared compared to robotic and open cases?
That's a harder thing to drill down to. I can tell you my complication rate has not changed. My infection rate has not changed. I am a member of the Michigan Surgical Quality Collaboration, which is 53 hospitals across the state of Michigan. They report all of our general surgical cases, and then they generate report cards in terms of where you stand amongst all the other hundreds of surgeons in the state of Michigan and where your hospital stands compared to the other 53 hospitals. Then they'll further risk stratify you according to the size of your hospital, whether you're a tertiary care center or not. And they will talk about all of those types of things and look at your complication rates. So I can tell you that my complication rates have not gone up. My outcomes, I will tell you, I'm doing larger hernias now and more complex hernias now that I have the 3D technology, because even I have people who come in, and I've had our administration come in and look at cases in our room, and I switch back and forth between 3D and 2D. I'll admit mostly it's because I like to get the oohs and the ahs, but there's a real big difference. When I switch, I'm going to use an exact example here. This week I was dissecting up inside the middle of the chest to take a stomach out of the chest, and I switched to 2D, and you couldn't tell where I was inside the chest. The depth perception difference is a phenomenal difference. And so once I switch it back to 3D, you can see exactly that you're about 5.5 centimeters to 7 centimeters up inside the chest. And you have that, there's a level of comfort that comes with knowing where you are when you're working around major structures. So I will tell you that that data of outcomes is going to be a little bit harder to collect because I don't have a lot of power yet, but the outcome data will come. In terms of, yeah, I think that pretty much covers it.
Thanks so much for explaining that, Dr. Bowden. This concludes today's program. I want to thank Dr. Bowden for his excellent presentation and to our audience for participating today. Enjoy the rest of your day, and we look forward to having you join us for future webinars.